Emergency medicine forces us to make high-stakes decisions with limited time and incomplete information. But sometimes, what shapes our care isn't just the data in front of us, it's the assumptions we don't even realize we're making. Implicit bias can influence how we listen, who we believe, how we interpret pain, and how quickly we act. Hi, I'm Dr. Ryan McLoughlin, and in this episode of Teach Me Something New in Under 5 Minutes, I'll walk you through how to recognize implicit bias in real time and interrupt it before it impacts patient care. Let's identify the problem. Most of us think bias is something we can consciously control, but implicit bias doesn't work like that. Key points here is it's automatic, it's unconscious, and it shows up most when we're busy, stressed, and cognitively overloaded, aka the emergency department. The clinical reality: you're moving fast, making rapid decision, triaging risk, and that's exactly when bias creeps in. Anchoring on first impressions, prematurely closing the case, letting recent experiences shape your thinking. What we think we're doing is objective clinical reasoning. What actually may be happening is unrecognized bias influencing diagnosis, pain management, and disposition. So what is implicit bias? Let's define it simply. Implicit bias is automatic, unconscious assumptions that influence how we interpret and act. And it's different from cognitive bias, which are errors in thinking, like anchoring or availability, and different from structural bias, which are system-level inequities. Implicit bias shows up clinically as undertreatment of pain, delayed or misdiagnosis, differences in triage decisions. The key idea here: you don't have to intend bias for it to affect care. So why does this matter? Because this isn't theoretical. It has real consequences. Bias impacts diagnostic accuracy, treatment decisions, and patient trust. In the emergency department specifically, this causes pain disparities, unequal resource allocation, and higher rates of diagnostic error. The clinical translation here is, if bias is present, patients don't just get different care, they get worse care. Let's talk about a framework for interrupting bias in real time. This is where it becomes actionable. Think of this as quick 3-step mental reset. Step 1, recognize the moment. High-risk situations include you're frustrated or caught in a visceral emotion. The story doesn't fit, or you feel very certain very early. And that's your cue to pause. Step 2, ask one simple question. What else could this be? Force yourself to generate a second diagnosis, reopen the differential, and this directly combats the anchoring and premature closure in implicit bias. Step 3, slow down key decisions before disposition, pain management decisions, or labeling a patient. Take 5 to 10 seconds and ask, would I treat this patient differently if something about them were different? Here's a bonus: micro behaviors matter. These are small but powerful. Sit down, ask, and use the patient's name. Acknowledge uncertainty about their care. These improve trust and help counter bias in real time. This is what it looks like in practice. You pick up a patient and immediately feel, this is probably nothing. This patient can't be in that much pain. That's your trigger. Pause. Ask, what else could this be? Recheck vitals, look for red flags, and consider those alternative diagnoses. That 10-second reset can completely change the trajectory of patient care. So let's wrap it up. 3 key takeaways. Bias is universal, but modifiable. It shows up most when we're rushed, and a simple pause plus second thought can change outcomes. So a final word: we like to think we're purely objective clinicians, but the best emergency physicians aren't the ones without bias. They're the ones who recognize it and know how to interrupt it.